We welcome you to Governance Dialogues, CEGIS's multi-sectoral webinar series, bringing together government leaders, practitioners, and experts to share insights on strengthening state capabilities. Each session in this series aims to spotlight critical themes in governance, ranging from health and education to public finance and nutrition, fostering change, collaboration, actionable solutions to improve developmental outcomes. So today's discussion marks the first in a three-part series to improve on nutrition and improved maternal and child health. Today's webinar called Building Bridges, Strengthening Systemic Convergence for Improved Nutritional Outcomes is being conducted on the occasion of 8th National Poshan Maah. This year, the government has also launched the Swasth Nari Sashakt Parivar Abhiyan, which is bringing the Ministries of Health and Family Welfare and also the Ministry of Women and Child Development to lead India's largest ever women and child health mobilization. The government aims to conduct 1 lakh health camps across the country to screen the women and children for anemia and other non-communicable diseases. So today's webinar seeks to explore the challenges and the facets of convergence between the ministries and departments of health and family welfare and women and child development through a system lens. It will examine the gaps between policy intent and on-ground delivery, highlight examples of effective coordination from all the panelists that we have today, as well as challenges that are faced in this convergence. And we will also discuss what state-level mechanisms and resources and capacities are required to make convergence work towards nutritional and health outcomes. So let me introduce our esteemed panelists for today. Let me start with Dr. Sampat Kumar, IAS. He is the Development Commissioner and Principal Secretary from Government of Meghalaya. With over 28 years of experience in governance and policy innovation, he leads the State Capability Enhancement Project, driving data-led, community-focused reforms that has reduced maternal mortality by over 50%, lowered child malnutrition, and expanded women-led SHGs. He also heads the Meghalaya Government Innovation Lab, fostering scalable inclusive solutions. We welcome you, sir. Next is Dr. Rashmi Menon, a research fellow in the Nutrition, Health and Diets Unit at the International Food Policy Research Institute, IFPRI. For more than a decade, she has been engaged in generating evidence and facilitating its uptake by program implementers and policymakers to support evidence-informed decision-making. With focus on maternal child nutrition in the South Asia region, she has been conducting several studies, impact and process evaluations, and evidence reviews and policy analysis. Welcome, ma'am. We have Dr. Sameer Pawar, nutrition specialist at UNICEF India with us. Public health specialist, Dr. Pawar has over 20 years of experience in the field of maternal child health and nutrition. He has worked across Assam, Madhya Pradesh, northeastern states, Maharashtra, in supporting public health and nutrition programs, specifically in the domain of HIV, immunization, and childhood nutrition. Welcome, sir. We also have with us Mr. Piyush Poddar, Director of Innovation and Program Design at the Antara Foundation. Mr. Bhatt is a public health leader and innovator with over 16 years of experience in designing and implementing scalable community-based solutions across rural India. At the Antara Foundation, he leads the development of high-impact community models that strengthen frontline service delivery. Known for combining grassroots insights with strategic thinking, he has pioneered data-driven, system-integrated approaches that empower government system and drive sustainable impact. We welcome you all. And we also, our moderator for today will be Ms. Parul Agarwal, who heads the outcome measurement vertical and supports the early childhood development projects in CEGIS. She has over 16 years of experience in measurement and evaluation of policies and programs using rigorous research methods. Prior to CEGIS, she was also with lead at IFPRI University, leading the research and advocacy efforts in financial inclusion and livelihoods. She has been a lead and co-investigator in multiple research projects on these subjects and also has worked with Women's World Banking as a consultant. So with that, I welcome everyone in the panel, and I hope all the audience have settled in as well. I request the audience members to put down their questions for either the whole panel or individual panelists in the Q&A box that is available in the chat box. And we will direct them to the panelists at the end of the discussion, subject to, of course, time availability. But we encourage you to keep putting your questions down and we'll address them. With that, I request Parul to take over from here. So, Parul.
Thanks a lot, Hari. Thank you. Hello, everyone. I'm really overwhelmed to be moderating this panel of such esteemed colleagues. And thank you, Sampat sir, for making time. And we know that you're traveling, you're on your way to the field, which must be really inspiring, as always. So let me just start. I think, like Hari just mentioned, right, like how convergence is also one of the themes for this year's Poshan Maah, right? So I think it's an appropriate theme for us to talk about today. So malnutrition, as we all know, is a major and persistent problem in India, and both WCD and health departments are trying to address the issue primarily through the frontline workers, right? Like the ASHAs, ANMs, and Anganwadi workers have a very important role to play in this. Some of their roles and responsibilities are overlapping, and ideally they should coordinate, right? But I want to get started by asking the panelists, like, what are some of the enabling and limiting conditions for these three community leaders, very strong community leaders, to come together and converge, right? So maybe Sampat sir, if you can get us started with that, that will be helpful.
Yeah, thank you. Thank you, Parul, and also Vijay and everyone from CEGIS and also co-panelists. It's great. I think your work is really great work. I really admire the CEGIS, the way actually you're trying to bring that state capacity, in through data and, to essentially bringing the interdepartmental collaboration ideas. Okay, so I just for your question, I just want to say, when we talk about convergence, we often talk about convergence, at frontline, mostly. But the key thing is that convergence cannot happen at frontline unless it happens at all levels. So convergence has to happen at state level, convergence has to happen at the district level, convergence has to happen at the block level, convergence has to happen at a cluster level. There is another layer before the convergence can happen at the community level or the village level. So there are five tier, I would see the structure. In fact, what we found was, what to facilitate that one, you require, this is one thing that basically it required. The second thing, we also have to see to make the convergence happen, it has to be a daily practice or a weekly practice, like SHGs, they meet on a weekly basis. Convergence can never happen, with one-off events. You organize one convergence meeting with, a senior official at the state level or at a national level. It doesn't happen. You have a good, or you organize a workshop, everyone feel good, and then they go back. They don't know how to actually practice convergence. Convergence is actually an organizational culture. So you need to bring that organizational culture to make it happen. In fact, at highest level, you need that political supportability. I call it political supportability because, political leadership should understand what it is, because the convergence can be really, authorized by the political leadership. So a lot of, in the state of Meghalaya, we have a human development council set up, at the level of the chief minister, and all the core ministers are members, and also the senior secretaries are the members, of course. So that way, what happens is that you have a lot of authorization is there, one. And then once that is there, then the at a different levels, this actually convergence can make it happen. So just like I wanted to say this, and and also it's easy, convergence to make convergence happen. If you start talking about purpose than the programs, then the convergence happens. Because, health department has to save lives of mothers and children. The WCD department has to do the same thing. And rural development department with NRLM is also focusing on the same thing. So if you can bring everybody together, basically, if you start talking about the purpose, I think then you would see a different way of working together. So what we did, one more thing to just like to sum up, we have one at highest level, we created this human development council. At a, at a cluster level, I would say we have this sector meetings are we organize very religiously with all people, having this every month, having these meetings. So some kind of a regular practice would help. I think there are already systems are there, only should make sure that they are actually functioning or not. They're not on the paper, but there is a practice and a regular practice. So just to sum up, I would say you need purpose before the programs. Two, you need to have a practice, practice, a daily practice, not one-off events for convergence. And three, you need an institutional mechanism, the entire the support that is required for ensuring and facilitating the convergence. Thank you.
Thanks a lot, sir, for that. I mean, like all these small things, can really make big change happen. So, yeah, we would want to learn more about how it is getting applied in Meghalaya. But before that, Dr. Sameer, if you want to come in and share your views on this.
Yes, thank you very much. Thank you very much, CGS team, for this opportunity and sharing my thoughts on this very important issue to deliver things for such a scale that we have in India. Before getting into nitty-gritties, I completely agree with bird's eye view that Sampat sir has mentioned. How should it happen from the top? But also want to acknowledge the scale that we have in India. So just a few numbers to know what are we talking about. We have something like 1.6 million habitations in India, which are supported for service delivery by 1.4 million Anganwadi workers, roughly 1 million ASHAs, and then 165,000 ANMs. And we want really, them to take care of 115 million children and 28 million pregnant women that have occur every year or annually. So such a scale, and we want them to really provide all those services at all points of time with quality on ground, with the only purpose that Sampat sir mentioned, to save lives and to create enabling environment for them to grow and thrive throughout their life, achieve their potential as well. Now, such a huge scale definitely demands coordination, which is critical. And on top of it, nutrition, it becomes further complex because it is like multifactorial, it is multi-sectoral, it is not really a cup of tea for one particular sector or one particular department to deliver on ground. So how do we bring all this together? And it goes beyond health and nutrition for achieving sustainable results. Now, some of my thoughts to really achieve these common goals, uh, we need to really find opportunities to harmonize effort and reduce duplication. Do we plan jointly when we really plan for our services? Do these, frontline workers or their top bosses or supervisors come together when they are planning for providing these services? Is there a common understanding between them on technical issues? Are there key messages which are like commonly understood and delivered in the same fashion by all of them? Needs to be really, really taken care of. Are there responsibilities? Is there a scope to rationalize their responsibilities? I'll give an example. There is something called as home visits, which are to be done by ASHAs as well as Anganwadi workers. There is a schedule for ASHAs. There is a schedule for Anganwadi workers. 7 visits by ASHA, 18 visits by Anganwadi worker under Poshan 2.0. There are some timings which are like coinciding with each other. How do they rationalize? Is there a possibility to rationalize? Is there a possibility to do some of them as joint home visits so that they become more quality and there is a commonality between the messages that are being propagated? So those are some of the things that really needs to be thought about when we look at convergence and create that enabling environments for the frontline workers to converge. My last 2 points on this: to create that enabling environment, there is a very important cadre called as supervisory cadre. Do we get them on board ever? Are they really willing to converge? Because they are in day-to-day touch with people, and we all work for someone or some organization. We know how we really deal with supervisors. What are we being asked by supervisors? We try and deliver that. So how do we get them on board? Lastly, very important, are their jurisdictions really rationalized? So ASHA might have different population, Anganwadi worker might have different population, and we want them to converge and deliver things on ground. There is a scope to really rationalize their jurisdiction so that their base population is similar for delivering those services. These are some of the thoughts that we should really consider when we look at convergence on ground. Thank you.
Yeah, thank you so much, Dr. Sameer. Like all these points are really, really useful, especially about the supervisory cadres, which usually get missed out, right? Like we talk about frontline workers, we talk about the convergence at the level of secretaries, but we usually do not think about other cadres and how they can be brought along. Dr. Rashmi, like, do you want to come in and share how your experience has been on convergence with regard to your work with IFPRI?
Thank you, Parul. And yeah, thank you, CEGIS, for having me here on this esteemed panel. And I think Sampat ji and Sameer have already laid out very eloquently the needs and how one should think about convergence. And what we have observed through research on the ground early on is what Sampat ji has put in as what is being actually done. Because our research shows that for convergence to happen at the ground level, it has to be mandated at the highest level. It's not that two departments are automatically going to come together and talk to each other. You need to have a higher institutional lead to bring that together. For example, at the level of development commissioner, at the level of chief minister, those are the powers to be, and at the district magistrate for bringing in multiple departments together. So which is actually the example of implementation is happening in Meghalaya. In terms of the other aspects that Sameer alluded to, in terms of how do we join, is there a joint planning? Is that what is necessary? Is it joint implementation or is it joint monitoring? I think we have to really think through this around what is really important. The mandates are clear. Frontline workers deliver on their sectoral responsibilities. In terms of going into the details of it, because in implementation, devil is in the detail, right? So if we think of the home visits we have talked about, when we say joint home visits or joint monitoring, one of the things that had come up in the field when we talked is the issue becomes how people manage their time to make these joint visits feasible. So one of the options is if they carry the same information, whether or not they go together or they go separately, there's reinforcing of the messaging, but they're carrying the same messaging, which means the training should be kind of either jointly organized or the materials need to be there to similar materials across board. And when we talk about, and then there are managing personal dynamics. What we have seen is at the front line, people usually they work together and, at the village level because they have their own personal needs. They know each other personally but what works in favor also works against. If there are small tiffs or if there are family dynamics or community dynamics coming in, then they don't work. So hence, we need some kind of an overarching mandate. So something from the state signaling that convergence is needed, which flows through at the district level, because basically districts usually ensure that whatever is the state is mandating is implemented. At the block level, pretty much there is no decision making. They are doing what needs to be done, coordinating, etc. And then action happens at the ground level. So how do we look at these various levels and ensure that they are all working together is super important. In terms of supervisors, I agree that they need to talk, but again, laying out clearly what is the purpose, because they have their own roles and there are serious issues of staff attrition at the supervisory levels. So if we also put burden of coming together, that again becomes a challenge. Not to say that it is not important, but thinking about what is the functionality of asking somebody. And to say to the Sameer's point around the synchronization is important between health and ICDS boundaries. This was tried out back in 2009, I think. Actually, UNICEF supported this in Gujarat. In Valsad district, they tried this out, harmonizing the boundaries so that for given PHC and the sub-centers are aligned and the same units are, the Anganwadi workers are grouped accordingly so that they are not scattered around. So I don't know the status of and this was expanded to the entire state of Gujarat. Now, I do not know if this kind of synchronization has happened across other states or not, but it is kind of useful to think about it. I'll stop there. Thanks.
Thank you, Dr. Rashmi. I think like all of these examples are, really important for us to learn from, right? Like what we are doing in Meghalaya, what is the Gujarat example that you gave, and that brings me to you now, Mr. But like while you share your views in the question, it'll be good if you could highlight Antara Foundation's experience, right, with AAA platform in Rajasthan and Madhya Pradesh, and any insights that you may have on what it takes to scale such convergence, right? Like, because we have been talking about these examples in concentrated geographies, but like, what does it take to, really scale it to a state level or, replicate it elsewhere? So, yeah, over to you.
Yeah. Thank you for the wonderful thoughts. So some keywords I have taken from Sampat, to me especially. Like when he mentioned that daily habit or weekly habit, it has to become an organization culture to work in a coordination. I think that is an excellent point. Second was they have to be driven by the purpose rather than driven by the programs. That is, all these are really important from AAA point of view, which I will explain in a while. And as Dr. Samir also spoke about removing duplication and building a common understanding about their work and what to do and stuff like that. And we also have talked about the supervisory cadre and the alignment which could be done at the block level or the sector level. I'll speak about that also. So quickly, I just want to give an overview of how this AAA platform works. So we started in Rajasthan in 2015, where initially we didn't think about the AAA platform. We just talked to hundreds of Anganwadi, ASHA, ANM, everyone at the outreach level to understand how they are working. And you will be surprised that we came to know that their data at the ground level, at the village level, was not matching at all. Like every village will have a single truth, but the truth for the village was different for the three women. We realized, and we also got into why. And these women were working with each other for years, but still the population, the number of households, the number of families, the high risk beneficiaries, they were not matching for them. So we tried to investigate that why that is happening, and we found out that their reporting system is like one ANM reports to the health department, Anganwadi reports to the WCD, and there's no mandate for them to sit together and rationalize their data, integrate whatever beneficiaries they have, or provide joint services. We also spoke to the beneficiaries, and what was most striking is from beneficiary point of view, they don't know health department, they don't know the ICDS or WCD. They just know from where to get the services. And they just think that these three women are one unit. But for these three women, the same person cannot be three units. So we worked with them and we developed a AAA platform. The AAA is a joint meeting which happens after the Village and Health and Nutrition Day. Once they are done with it, they sit together, they jointly review, they jointly plan. They, as Dr. Samir also said, they share their learnings with each other, and they focus on the high-risk beneficiaries. So the first place question was whether what should be the way that their data gets integrated, at least at the village level, right? And that will travel to the state level. So the problem is at the village level at first place. Of course, there needs to be a willingness. So we worked out a village map with them, where community also participated, and the three frontline workers co-created that village map. And they had after that activity, they had the common household, common families, and common beneficiaries. And interestingly, in most of the cases, all three women were not right. I mean, Asha wouldn't say that my my numbers were right, or Anganwadi would say no, it was not like that. The fourth thing was the correct thing. Like if she was saying I have 9 pregnant women, the other was saying 8, ANM was saying 11, so actual number was 13 or 12. So basically that helped a lot. So we created 46,000 village maps. We started with 25 villages, and that program was scaled up by NHM Rajasthan eventually. And after those village maps were made, they were digitized, and high-risk beneficiaries were identified, and bindis were put there, and the integrated tracking system, began from there. So that was AAA platform we did in Rajasthan, and then we came in 2019. We started Madhya Pradesh. And for the, I think for the question where we were talking about, uh, this integration is required at all levels. I completely, take this point, because rationalization of roles and responsibilities is possible. That integration is possible, but everyone has to come to the same page. So we actually had an MOU with WCD and Health Department, both Rajasthan and MP, and that actually helped to set the common goals and shared understandings of everything. In MP, we are working in almost 5,700 villages in 8 districts, where we have implemented this AAA platform, and we really got good results, where we saw that the coverage has increased, the high risk identification in these places have increased, and most importantly, there are a few pointers which I want to make, which are very integral part of this whole thing. One is the joint planning, developing a village map, household, and based on that, tracking the high risk cases, collective identification, sharing that data with each other. Like Anganwadi would have identified 2 SAM children, or Asha would have identified 1, but they will not share with each other, and ultimately the beneficiary is affected by that. So that collective identification is something which is an integral part of the AAA process, and integrated service delivery. So I think you spoke about the need of joint visits, or collective problem solving. Like there are community level barriers where very little information is given, that how do you deal with it. Like if a beneficiary is denying to take that service because of access, or because of any other issue, or any community issue, how do the AAA solve it? How an Anganwadi worker would be supported by ANM or ASHA in those visits collectively. So that is one part they plan together, and they basically have a better data and shared responsibility after that. This actually, and I want to give one specific example about this. Identification. Once SEM is identified, ANM, CHO need to screen whether that same child is having any medical complication or not. Based on that, that child will go to the NRC. But when you see the departmental review, in the health department, their indicators will be prioritized for review, and similarly for WCD. So that becomes really important. Somebody has to be accountable of whether you have screened or not, whether you have sent those kids to the NRC, and that is a shared responsibility. So when you talk about the shared goals or shared objectives, that is something which is missing at the top level. And Dr. Rashmi pointed out about this, at maybe at block level or at sector level, those sectors are not integrated. And that is why at the supervisory level, it is a huge challenge to bring, all of them together to do the, joint visit or commonly solve the problem, because their sectors are sometimes overlapping, sometimes have different geography. So I think that is a huge problem somewhere. And if that is solved, I think 30% of this problem will be solved, because that will give them a platform where they can do that joint review. At this point in time, I will say that there are no such platforms where they can come together and review for the same geography. So this is one thing. But just want to make this clear that at the field level, village level data integrated integration is important, and village level integrated service level is important, and at the same time reporting, consistent reporting is also important. I may report to the MPR as an Anganwadi. I can fill an HMIS form, but the numbers have to be same and it should come from the AAA meeting. That will also synchronize those numbers, integrate those numbers at the state level, so you won't see that difference in the data. So at the end, I just want to re-emphasize on this that AAA is all about integrating that data at the ground level. And second, planning integrated service delivery, especially for the high risk neonates, high risk children under 5, and the pregnant women. So this is the whole thing. Currently, we are not working in Rajasthan. We have handed over this program to government, which is called Raj Sangam now. They have complete ownership of it, and it has been scaled across in 46,000 villages in Rajasthan. In Madhya Pradesh, we are in 8 districts, and we have implemented this, and now we are looking for scaling up opportunities across.
Great. Thanks a lot for that. And I think like that's a good segue to my question to you, Sampat sir, right? Like it's clear that, convergence needs to happen at all levels for seamless functioning and sustainability and improvement in outcomes that we are targeting for children and pregnant and lactating women. But we don't see many of these examples, right? So what are some of the, systemic and institutional barriers that currently impede this effective collaboration between the two departments and ministries, both, I mean, at the state level and the central level? So what do you, and also like if you could share how it is working out in Meghalaya, that will be really helpful.
I think already the speakers have spoken on that front. So in the sense, like, what are the barriers, So I think I really like the Valsad model. I think I hope such kind of ideas would definitely be helpful, because even, while coming to this meeting from another district, the same problems have been highlighted, that, the health blocks are different from ICDS blocks, and ICDS blocks are different from the administrative blocks. So these challenges are there. So what I think while we definitely fix those technical solutions, I would say we also need to work on the adaptive challenges for convergence. So I wanted to differentiate between technical versus adaptive. Technical are, we can do it. Sometimes technical problems are also adaptive problems, but so the adaptive problems are, again, the bringing that purpose, how actually we are sharing that vision, so repeatedly, and bringing that sense of purpose. A lot of this organizational culture needs to be changed. This is one. Number two, there are also some challenges. For example, these departments also are implemented or administered by different ministries, different programs. So if the ministry's priority is different, they make sure that, like, so because you monitor in such a way that sometimes the frontline functionaries try to engage more in data collection and reporting than actually solving a problem. So this is a problem across the departments, across many programs that we have been observing. So in that case, what is our role? Okay, we have to provide a kind of a holding environment, I would say. Holding environment are, someone has to take a buffer, someone has to take the shot, at a state level or a district level, that okay, have that, you need to participate in the campaign, but while participating in the campaign, you also actually focus on this, our state priorities, this, our priorities, our priorities. So I think that communication is important. So because of in this hierarchical structure, sometimes you don't really give that kind of a holding environment for the frontline functionaries to really express their challenges, and to really solve the problems, even though they have the intention. So I think, so these are some of the adaptive challenges, I would say. So to bring that, we need to bring that organizational culture, and and once we start doing it and start, producing the results, I think, even at the highest level, you get the support that is required, for this kind of a change that we wanted to see. I think, I think I've said this one, but like which very interesting what we're doing interestingly in Meghalaya. So one, I was listening to Antara Foundation. I think this is very interesting work. I think is it Mr. Ashok Alexander's work? I don't know, like what is the foundation? I'm sorry. So I see in fact, so there is a when we talk about the data, like use, not data collection. What we try to do, in fact, we created at a village level, we created an elected village health council, which actually brings the kind of a convergence of the programs of all the 3-4 departments put together. So one, and then we started actually sharing the data with them. So we have taken APIs from Poshan Tracker and also from the RCH portal, and given this nuanced data, like these many high risk pregnant mothers are there in your village. So, and we started only, through a small application, Village Health Council app. We started actually also, getting their participation. So we are finding very interesting things, how to actually enhance. This is one part. The second thing I would like to say, to build that, sense of purpose, and the problem solving abilities to the frontline functionaries. We also started, we launched a program called, Human Development Leadership Program. What does it mean? All the 4 departments part of the human development leadership, they go on a weekly basis, a field visit. There are, in every block there are 3-4 teams are there, and in fact this is actually being now is going to be evaluated by Dan Honig, one professor at UCL. So there is a, so what we are trying to do is that these people would go, and they, based on the data, based on the Poshan Tracker, based on our mother portal, we identify who are the most vulnerable households, and then they go and you know uh, visit the houses collectively, and the main purpose is to listen to the problems, to empathize with the people. So in the process, they develop empathy, they develop sense of purpose. It's a very interesting way. Actually, we are seeing a very, very, instead of this, through this practice of like weekly practice, we are seeing a very interesting, in fact, most of our block development officers, who are the, state civil service officers, civil service officials, they are in fact leading this work, at a block level with different teams like block medical officers, CDPOs, and different APOs and all that. So it's a state is investing in to build that citizen state connect. If you build that citizen state connect, and also, what happens is that a lot of this, problems can be solved effectively. So these are all. So these are the few things that we are trying to do. And please excuse me. Yeah, thank you. I might require to leave early.
Oh,
Thank you.
okay. No, thanks a lot, sir. I think we will set up a longer learning session with you to learn more about the work, inspiring work that is happening in Meghalaya. So, sir, just because you have to leave, I'll just ask the last question first, and then we can continue with the rest of the panel. So, what would be the one action point that you would recommend for organizations in the ecosystem like CEGIS, IFPRI, UNICEF, Antara to facilitate this convergence, right? Like what will be, like how ambitious should we get if we were to set a target for ourselves for, let's say, next 2 to 3 years, one thing that we should do that will help in facilitating convergence, then what should that be?
Yeah. So basically, it's again practice. So we might require to work with, this is what, in fact, IFPRI, they started working with us. In fact, what we did was, we did an exercise for the district nutrition leadership program. We just did, what we did, we brought all the, with the collector, the deputy commissioner, we call, DC, and then all the DMNHO, medical officer, ICDS officer, and NRLM officials, all of them were brought together. And then what we did an interesting exercise. IFRI has a research, the data showing the NFHS data district wise, then asking them what surprised them by seeing the data, what they can do by themselves, what actually, what support they require from the state. So I think through practice, I think maybe like you have been already doing in other states, like I know CEGIS is doing in Telangana and other states. So I think once we do, we take a problem, I would say take a challenge and try to mobilize I think through addressing that problem, you can actually bring a lot of convergence practice. So the convergence practice would come by solving a problem. So I think take some huge challenge. For example, for Meghalaya, we have put a challenge like half foot challenge. What is it? Half foot challenge means or stunting. So by the time like child reaches 1,000 days, the child should be having at least 3 feet, but on an average, our children are having 2.5 feet. So how can we actually increase half foot? So that actually bringing everyone together. Yes, I think then what I should do, like each one is contributing to that. So I think with this, I think you're great, minds that you have here. I think we can learn a lot. Thanks to and knowing each one of your work. Thank you so much.
Thank you, sir. Thanks a lot for your time. Yeah, so Dr. Samir, my question was to you next, because as Sampat sir mentioned and Piyush also hinted at it, like ideally technology and digital data systems should take care of some of the issues with regard to, data quality being poor, etc. Like, but, with platforms like Ocean Tracker and RCH, some of this convergence should ideally be possible at different levels, because data is available at different levels, right? It's coming ground up. But based on your experience of working with such platforms, like what do you think is the potential of this real-time data and enabling coordination, right? Because I mean, there are still challenges with access to data and all, but then what is the potential of such data systems that we should try to harness, and how to make it happen?
Yeah, thanks. That's a very important question in today's era, when everything is digitized and everything is on mobile phones. Let me start by sharing one of my experience from the past. Around 20 years ago, I was a consultant in one of the district in Maharashtra called as Nandurbar. And I used to visit, sub-centers, Anganwadi centers, and try and interact with ANMs, ASHAs, as well as Anganwadi workers. And I used to ask this question: why do you, put things in register? Then there were no applications and mobile phones, but they used to, record it in the registers and report it upwards. And the understanding at the ground level was that it is required at the state level. That's why we put it in the record and we send it to the higher ups. So it's very important to change first the mindset that it is not required at the higher level of governance, but it could be used even at the service delivery point to really improve, adjust, and change things on ground based on what you see through the data. Now, you mentioned about the government platforms, and government has made a significant progress in last few years in terms of digitizing several of its schemes and platforms to get more real-time data. HMIS and Poshan Tracker is one of those two examples, but there are several other applications, several meaning probably in hundreds of numbers. You have SNCU software, you have NRC software, and several others, which are state-specific as well as central government driven. Now, what happens is, first, information becomes available through these platforms, but also several challenges come with it. Now, first thing, do these systems talk to each other? So they are developed on different platforms, different architecture in software language, different unique used by different platforms, and hence they are unable to talk to each other. So Poshan Tracker, getting data from Poshan Tracker into RCH2 portal for the same beneficiary and aligning it through the technology is a huge task even now. And then a simple solution like aligning unique IDs might help, but that's what has not happened because they were developed at different points of time with different purpose by different people or different entities, and that's why they each other. Number two, as Sampat sir mentioned, is there a burden on frontline workers to put that data into that platform? sometimes I feel, and you might feel that I'm sarcastic, but sometimes I feel workers are more concerned about putting the data into those applications rather than delivering the service, and that's becomes a big challenge. And then there is duplication of data. So immunization will be captured by Anganwadi worker also, ASHA also, ANM also, RCS2 portal also. And same child might have different immunization status in different platforms. So again, a problem in terms of duplication. Uh, and then the question comes whether it is being used, analyzed, and acted upon. I think yes, it is being used, but not really with the purpose that it was due. So how do we do this? How do we make it happen? My suggestions are like, first, streamline the data collection systems. Let the systems be interconnected, integrated, and let them, technologically as well as operationally interconnected, so that no one has to collect data that is not required for them, for their purpose. Number two, very critical, how do we identify at risk or vulnerable, maybe families, children, or women, using that data that is coming on a real time basis? Because the whole purpose is really to provide those services to those who are at risk so that we save their lives or we help them improve upon their status. Targeted service delivery is something that could be really potential from the data that comes. Cross-sector collaboration. So if an ASHA is going to a household and she finds something which is related to say, take-home ration, then there should be a mechanism for ASHA to flag it to the Anganwadi worker so that take-home ration related problem is solved. Collaboration is something that could be really easily possible using these data platforms, and it goes beyond health and nutrition, like PDS. So those, if you find the family is so vulnerable that there is food insecurity, then linking them to PDS is something should be possible for ASHA. But ASHA might not even think about it because she is not mandated to do that. But there should be some mechanism for her to really push that information into that platform where it is possible. Flagging vulnerable cases like those who are with repeated illnesses or any other vulnerability that they could identify, they should be able to flag. Hotspot mapping is something that is very critical and possible using data. So identify those hotspot within villages or within the blocks so that even supervisory cadre could provide more focus on those hotspot areas for providing those services. And of course, we know that government system has review mechanisms, and data is something that could be potentially a very powerful tool to do evidence-based reviews, and also stop blame shifting and trying to focus on addressing those challenges and identifying solutions jointly using data is something that we have potential from the data system that really strengthen them, use them correctly. Thank you.
Yeah, no, Dr. Sami, like this resonates a lot with us, and especially me coming from measurement team of CEGIS, like this topic is very close to the heart as well. I think one thing that we are also trying to do is figure out how do we, analyze the data to identify hotspots or to do some predictive analysis to identify at-risk children. But then we get into that vicious cycle because the data quality is poor. So you can't use poor quality data to do any predictive analysis or use any new age technology or statistics to, do some of this. So there, like, we feel really constrained. But you're absolutely right. Like if the data starts getting used on common indicators in the review meetings by all departments, then we can still make some progress. But like, have you come across any states, or like, are there any examples in your mind where these reviews are happening in such a collaborative way, where maybe like a health officer at the district level is reviewing both nutrition indicators and health indicators, or a DW?
Very rarely, I would say, very rarely, because they are not designed to do like that, and that's where the problem is. Number two, the very important point that you said, I have two kind of suggestions on that. One is, data validation mechanisms. So does supervisory cadre go and validate some of the data on sample basis? If that starts happening, quality might improve. And number, start utilizing what you have. As you go on utilizing data, you will give feedback to the people on ground, and then data will improve in quality. Unless you utilize it, you won't come to know how it is changing.
Yeah, sure. I see Vijay, you smiling. Like, do you have any follow-up questions on that?
No, I don't want to get into the panel's discussion,
Okay.
but I'm agreeing to what is being discussed. So thanks.
Great. Okay, so Dr. Rashmi, because actually Dr. Sameer also hinted on convergence not being just restricted to, nutrition and health departments, but it is much wider, right? Like there are many more determinants to nutrition outcomes beyond health practices. It is linked to WASH, it is linked to a lot of behavioral practices at the household level, dietary diversity, and a lot of these things are very community driven, not necessarily falls within the mandate of a particular department, and some are with other departments. Like PRRD takes care of WASH in many ways, and I know that IFPRI has done a lot of research on mapping these determinants and the factors. So do you have any suggestions on like how the convergence should be thought about, right? Like beyond health and nutrition, and how can it be facilitated in a localized manner, right? Like, is it possible to do it at a panchayat level or, at a district level? So what should be that unit of convergence as well?
Thanks, Bobby. And I just want to say I couldn't agree more with what Sameer said about data systems. And I'll come back to that. In terms of, you're absolutely right. Nutrition is usually expected to be addressed through the ICDS and health systems, but there is globally known examples of success cases of improvements in malnutrition, and also in India, where we know that there are multiple contributing factors. There are multiple determinants, and hence we need to think about nutrition being not the onus of only these two departments. These are, of course, they are very important, but not, that doesn't end. Now, if we think of that, then when we talk about convergence, it goes beyond two departments. So, I mean, I would like to think about what Sampatji was talking about, a purpose, and I was thinking in my head about administrative versus functional convergence. Administrative is how we are thinking about, okay, how these workers will work together, how do we bring two sectors together, etc. If we think about the functional convergence, who are we doing all this for? It's the mother, the child, and the households, right? So there are multiple determinants to improve malnutrition. Yes, health, ICDS related services, WASH, maternal education, having clean fuel, all these things, and household level wealth, all these are important. And food security. Do we have programs for all these? Yes, there are programs. Now, when we talk about convergence, where do they all converge? What are they converging on? It is for those households that need all these services. So if we think of convergence from that perspective, how do we get all these services converging on those households? Not thinking differently, slightly from how we are thinking about how departments should be working together. Because for health and ICDS, it is a little bit easier to think about, or do they do joint visits? Can they do joint supervision? Because the functions are kind of overlapping or in a similar dimension, right? They are talking about improving behaviors or giving supplements, etc. in both cases. But if you think of water sanitation, if you think of education, PDS, they are in a very different realm. So how do you think about those services coming together? Then we are not talking about convergence between departments. We are talking about co-coverage and those services converging on the households. So that is my first thing to think about. How do we make that happen? And if we think about that, then build back, right? So what would it be require for us to make that happen? Then, okay, who at the district level could be an in charge, who actually has the power to call shots to talk to all these departments. It's usually the district commissioner or district magistrate, right? So when Poshan Abhiyan started, the 1.0, right? So one of the mandates was there should be quarterly meetings at the district level convened by the district magistrates, bringing all the departments together. And there were some key indicators that were identified that the district magistrates would be checking on, right? Something similar to that could happen. So I would say, think of the mom, the child, and the household, and plan from there when we think of numbers. So that's my take on it. And I mean, based on what we have been thinking, because one of the other things our data shows is when coverage is really nearly reaching, let's say 90%, right? I'm only talking even in this terms of health and nutrition. Then co-coverage could be decent. But if the coverage is at any between 50s and 60s range, then the co-coverage becomes even smaller. When I say co-coverage, whether the mother and the child, when the mother is identified for pregnancy, did she receive all the interventions from the health department? And as the child is born, after the institutional level, is the postnatal care being done? And then in that same diet, are they still receiving behavior change communication? And is the child receiving vaccinations, pediatric IFA, etc., right? So when we think of co-coverage, that becomes very limited. So how do we increase the numbers? So thinking about from coverage to co-coverage, a shift in the thinking. And when we think of the data systems, again, thinking from that perspective. So not duplicating, if you look at what the ICDS data that gets collected from NPR, how many of those indicators are actually really used ever? And what are those indicators that are actually need to be used and they're never there? For example, IVCF quality of counseling, right? So some of those things need to be thought through really before we ask frontline workers to start thinking about working together. They are extremely busy. Their workload is very high because they have to keep reporting, putting these things to, getting all these numbers, getting them by before the 30th for their sector meetings, etc. So yeah, I'll stop there.
Yeah, no, great. These are all very useful points, and especially the first one, right? Like, who are you doing this for? Actually, this has been a realization for CEGIS also lately, right? Like, while we work on systems and system strengthening, like ultimately, who are we doing this for, right? So, like bringing in a lens of people level outcomes and, thinking in that direction and keeping that goalpost clear really helps us prioritize and target our interventions better as well. So just a quick one on when you say that your household is the unit or your child or the mother is the unit, like, is there any role, because we also haven't come across any good examples of community being given access to data, right? Or them being told what is the status of your child, right? Like in a very, I mean, ideally they are supposed to know, but there are no such successful interventions around data transparency at the panchayat level or at the household level, where the panchayat gets to know that these many kids in my panchayat are malnourished, right? And therefore it's a joint community effort towards it. And it's not just the job of our ASHAs, ANMs and Anganwadi workers, or a mother getting to know that, my child is malnourished and therefore I also need to work with the Anganwadi worker towards it, right? So, and like taking it back from Sampat sir's point, that like how do households and AAA work together, right? Like as a single unit. So like what are your thoughts on it? And I mean, like Piyush, Dr. Sameer, like any of you may come in, and any examples of such successful cases.
So yeah, so quickly I want to take you through two things. One is Dr. Rashmi is also already pointing out. I want to talk about joint report. Now, this joint report is basically a format for AAA, which basically the AAA, these are it has the common indicators for health and WCD, like all the indicators which are reported in MPR or the HMIS form. All those indicators are being incorporated in that common format, and that is not a format which they will fill and they'll submit to anyone. But after matching their registers with the existing data, they'll jointly agree on the data points and they fill the joint report. Now, this joint report they use to fill the MPRs and the HMIS form. So the data consistency remains the same. So this is one of the tools which we have successfully implemented in two districts here. And it has reduced the variance between the two departments by 20 to 30%. So for most of the coverage indicators. So I think one is that is something which is really useful. Second, I want to comment on the community part. So we are also we have enhanced the AAA now, and it is called the CAAA, which is Community AAA. So here, what we do, we basically mobilize community groups like the participatory learning approach you have heard about. Ekjut is doing PLA; they are also our partners. Then in the areas like Badwani, where the villages are scattered and they are divided into many hamlets, one village would have 10 to 12 hamlets. So the coverage becomes really difficult there. So how do you involve the community through the volunteers from those hamlets and tie them with the AAA process so that they back and forth help in tracking those high risk cases. And we also have the Mothers and Enablers group, which is basically the Sayogi Mata Samiti of WCD, and pushing them basically to do certain meetings in a structured manner where they could help behavior change of other members in the group. So these are the community models we are implementing specific to the geographies. But what is common about this? Common is the high risk beneficiary data is shared with the active community members of the irrespective of the geography. And we basically focus on shared responsibility of tracking these cases, especially where community issues are coming in, where the family doesn't want to take the service, they don't want to go to the NRC or the SNCU. There, the community comes in and takes responsibility, and these people are actually the active community members from these community groups. So now that is basically that was the thread which was missing from our ecosystem, and we connected it well. So we are basically trying these community models in different parts, but what is common amongst all the model is that the community is being tied with the AAA model, and it becomes the community AAA. Active community members from different community participate and take shared responsibility. Why they would take? Because they are being trained in that way. So because there are the various village level platforms under WCD and NHM both, but consistently involving community in the whole decision making process is the critical point which is actually missing. And if you will see, like Poshan Maah or any other event, what we do is we basically use the community in a campaign manner, and that is something I think that is good, but there has to be a consistent input to the community to bring that behavior change. I'll give a small example of this, like nutrition during pregnancy. If a woman takes THR, that doesn't necessarily mean that her nutrition status would improve significantly until she improves her diet habits at home. Now, why would she do that? Why would she do that? So she needs to understand what are the best practices, what would happen in what condition and circumstances, and that is why a full package of awareness and community empowerment needs to be there consistently, where community basically help themselves first and then gets tied to the government system. Second thing I want to emphasize here is the use of real-time data. We have talked a lot about collecting data and stuff like that. But if you see, still there are missing elements in the system where the data, one is that data is not used. Second, there is still missing system where you will see that the data is not available also. For example, a kid is discharged from NRC. Now, sometimes Anganwadi worker would not know that the kid has come back, or a neonate is being discharged from SNCU. ASHA wouldn't know that the child has come back because that information is not traveling to them. Now, just correlate it with the outcome, you see that the majority of the deaths happening in neonates are between first to seventh day of birth, these critical 7 days. And by the time that information reaches to ASHA, you will see we so second part is that the real-time data system still has gaps, and mostly we rely on a system which is not integrated and have a lot of duplication. So we are currently working on this with the government to build a system where data is used for planning, for used for actionable reviews. We call that intervention anugami, and we are working in 8 districts on that. Identify which are the data points very critical, which have a larger window and which have smaller window comparatively and would lead to bad outcome. So we are basically working with the government to make that data actionable in terms of who does what without adding any extra responsibility to the frontline workers. So all these things are, I think, really good things happening around, and some partners are also working around all these things. So it's really good that we have such platform where we can, our different point of view get together and we think of common outcome, because end-to-end tracking is so important from the pregnant woman point of view. Set aside all the portals and everything and just think of that if a pregnant woman gets registered till the time her kid is say 5 years or 2 years old. So there are various stations where you will see that the loop breaks, and because that data is not available and there is duplication of data. So till now, we see that there is no system which end-to-end tracks the nutrition outcomes also and the clinical outcomes also throughout this process. So we are working with the government to basically build this bridge, pilot a few more things, and yeah, and learning from all our partners in the process.
Thanks a lot. Thanks for that detailed response, Piyush. I think we can take a pause here and gather some questions before we do the final one. So Hari, if you want to come in.
Yeah. So there are a couple of questions. I think we can start with one related to convergence across state capacity. So there is a question. I want to learn more on convergence across state capacity. Access to nutrition and services for early childcare are also disproportionately distributed across different states in India. How can we address closing this gap wherein a child born anywhere in India has access to similar quality of services? Any one of the panelists can take
Any
this.
panelists can take
Yeah.
I just lost network for 10-15 seconds, so I'm sorry about it. I just couldn't hear it.
Shall I repeat the question?
Yeah, Hari.
Yeah. Access to nutrition and services for early child care are also disproportionately distributed across different states in India. How can we address closing this gap wherein a child born anywhere in India has similar access to quality of services?
Okay, so maybe I can try this. So I think that's right, and the basic thing which is required is that the community issues needs to be part of the whole planning. Because if you see geography wise, so for example, in MP only and within that state, if you see there is a tribal population, there is non-tribal population, there are compact villages, there are scattered villages, and sometimes access to the care which they get at the facility or at the outreach becomes really difficult for them, irrespective of whether they want or not. So, and we see that the representation of these communities is also fragmented. It's not that you'll see that one pocket is completely missing from the whole planning. So I think inclusion of the community in the planning and strengthening VHSNCs helps a lot. but mostly you will see that it is concentrated in, one Anganwadi center or on one part of the village, and that is where the problem comes in. So community needs to be the part of planning. Only then this access to facility problem, get somehow solved. Because what we see is even in the geographies where supplies is strong, still the outcomes are not great in terms of access and other stuff. So that is basically because of the fact that the community is not tied up that way. And where we have tried doing that, they have given, better response and showed better accountability. Yeah.
I can add some to that. What we have learned doing the success case studies in the states across in India, and these were varied states. We looked at Gujarat, Odisha, Bihar, Tamil Nadu, and some of the common elements across this are whether and I'm speaking to ensuring the quality of services. What we looked at is the coverage. It has to start with the intent at the highest level, leadership, right? That has to be political intent. What we had seen is there was a purpose to achieve either reduction in MMR or improvements in child growth. So there were visions and missions at the state level, which were facilitated by capable bureaucratic leadership. That it was stable for across several years, and they were innovative. And all these were possible while operating under the common national framework. The programs are same across, the national programs, ICDS and health are same, right, across the country. Now, how they get implemented within each state is different, and the flavors change because of some of these aspects where leadership is there, and then the state innovated using the existing funding, putting in additional and partner support, joining forces. They were able to innovate within and strengthen the systems to deliver the existing interventions. And then putting in place monitoring and strong monitoring and learning agendas within the state. So some of these things have helped in these states that we have studied. And learnings from some of these states could perhaps be taken in other places to improve the quality of services. Thanks.
Thank you. There are a lot of questions related to data system integration. Let me ask like a couple of them combining. So there is one question that says that even if Poshan Tracker collects child nutrition data, how can India move beyond chasing SAMM numbers for global reporting and instead integrate this data with health system platforms like Reproductive and Child Health Platform or HMIS to create an interoperable convergent framework that identifies at-risk children, women early and reduce frontline worker duplication and drives joint accountability across health and ICDS. And also, there were other questions about integrating data systems at national level. And with Aadhaar playing a role of rationalizing several databases, and there is Abha ID in health, and some of the state governments also have family IDs. So centralizing of data system in a way that it can be convergent with other data systems is a huge area of interest for everybody, and even the government is working towards the same. So one is how do we, lead to this? How do we lead towards this interoperable data systems that can help early detection? And the other is, are there any risks that you foresee with excessive centralization? What kind of risks does it pose, and is it? What are the pros and cons of it? So, this centralization, converging, and interoperability of data systems.
Can I come in?
Yes, yes.
Yeah. So just to really, putting them all together and trying to update on what is happening at the national level now is something called as RCH 2.0. So RCH portal is getting revamped and updated, and it is now looking into, creating that interoperability or interconnectedness between the existing like Poshan Tracker or whichever data sets they exist. And there will be a unique ID for each of the beneficiary, either mother or a child. and the child and the beneficiary will be linked through these systems. So that is being tried under RCH 2.0, and hopefully it will take care of all those issues related to, systems not being integrated with each other, um, and also reducing data collection effort or data duplication effort, with a streamlined kind of data collection across the life cycle once the beneficiary enters that system, may be done by different functionaries or different departments, but linked to each other. And that definitely will, take care of also identifying those at risk and flagging them with different systems. So even if somebody is identified with risk as for health, like with illness, but that should also be known to the Anganwadi worker or ICDS system, so that they also are able to take care of that child or infant as and when needed. So that's something that is coming. Of course, chasing numbers, India doesn't report to any global forum on numbers. They are only there on the Poshan Tracker dashboard, and that too a very limited kind of indicators are seen on the dashboard. So India doesn't really report on any numbers. But yes, since the scale is huge, how can India focus on those who are at risk so that you are able to take care of them, rather than spreading ourselves thin in reaching out to all the beneficiaries with similar efforts across all the beneficiaries. Uh, Centralized, decentralized, it's a very, very interesting question, and probably we need to really study going forward. You will see some of the states, especially down south, who want to have their own systems, mechanisms, indicators going beyond what is being collected from the national level or centralized data systems. Like, for example, Telangana has its own NHTS, while there is Poshan Tracker and RCH2. Uh, so having decentralized has some advantages. You have your context specific data that becomes available for you to act, but it should not put on extra burden on the functionaries to punch in same data into two different systems, just for the purpose of sending reports to two different systems. I don't know why it is not possible to really have these centralized as well as decentralized systems to talk to each other. Even for Poshan Tracker is a centralized system, wherein states have access to dashboard, but they don't have access to the whole raw data. And then there is a mechanism some states have created to really have those APIs to back their own data for further usage at their end. But I think technologically it is easily possible to really link them and have access to these kind of systems. It just probably requires some more push at the political level, so that governments are able to make it happen, or make at least enable it to happen. Anything I missed? I don't know.
No, I think you covered all the points, and the last one in particular is something that we have also been trying to push for, but seems like it'll take some time to build salience at all levels for data integration, data sharing. Because ultimately, like again, coming back to Dr. Rashmi's point, who are we doing this for, right? I mean, if everybody starts thinking that way, then all of this should be made possible, especially now that technology is on our side. Do Dr. Rashmi or Piyush, like, do you want to come in on this question around data integration? I had a last one.
No, I think just one point I want to add, that also I mean, as a country, we have obsession of collecting so much of data. And there are, many data points which, I mean, if you see a pregnant woman's journey, you will find that there are, say, 5 to 7 such points where, the loop actually breaks. So even for the kid. So even identifying those data points and making them actionable, and building a system which do not have the duplication problem around at least these data points will still solve a problem. So for example, high risk pregnancy management, If a severe anemia woman is identified, she has to be managed. And the source for that should be one portal only. Like for SAM kit, there should be one portal only. And I think where the opportunity is how can both the departments have a link through common APIs and share that data with each other, and that is visible for all the counterparts, all the functionaries. I think still the problem will be solved, and collection of data and integrating of data is probably still the secondary thing. The first thing is that how do you use what you have at the field level, right? I think that is the primary thing, and still from that bunch of data, you will have those points to start working. And as we started this conversation, I want to come back there. The three women sitting together, if they have a common and shared understanding of their beneficiaries, their data in the register, and they track them and they provide them integrated services, everything will fall in place ultimately. So the use of data has to be emphasized, at least at the outreach level and at the level where that data should be reviewed by the right functionaries. Because system integration is going to take a lot of time, to be very honest, because many departments, many ministries are involved, and it is going to be at its own pace. So the important question is that what do we have in our hand and how that can be optimally utilized at the outreach level where the beneficiary lives, at the outreach level where the frontline worker is delivering the services. I think that is the first question where the integration needs to be, happening. Yeah.
Yeah, makes perfect sense. Vijay, I see your hand up.
Yeah. So when we were talking about the convergence as topic, I could not avoid thinking about one aspect. Yesterday only, I had this experience in one of the CM's office where we were there, some other partners were there, and I just overheard the conversation of the coordinating officer at the CM's office, who was saying, okay, almost every second day they get one organization who is asking for some data from a particular department, and the department's bandwidth to just give data, they are spending so much time on giving that data. So it's not only the problem of convergence within the government departments, also so many good people, and more I work in this ecosystem, I'm coming across so much good work is happening. Probably there has to be some thought on just bringing what is happening, just rather than thinking anything new, just bringing that together and funneling it through a common channel with the government before we really raise our individual requests with the government, which has a limited bandwidth and capacity, as we are aware of. How can we have that kind of mechanism first to curate what we need together, and maybe go at that regular frequency to the government to avoid the maybe a completely different thought on convergence. I just wanted to put on paper on table here. Maybe we can pick it up at some later point, but I thought this group can really kind of think about, at least on nutrition and these aspects, to start converging outside the government before approaching the government and before asking government to converge, that both the aspects. So just thought of putting that on table. Thank you.
Yeah.
Vijay, can I come in here for
Yes,
a second? The other part of convergence is just like different partners could be going and asking the government could be going and asking different partners for the same thing. So then having a common platform and understanding between various partners, so that whoever gets asked, we are kind of on the same page in providing the solutions. Otherwise, giving different solutions to the same problem could confuse and diffuse the energies. And to that extent, I mean, Samir, you are aware of this. We have at the national level, there used to be coalition. I think it still is Coalition for Nutrition Security. It was a platform, vibrant platform for different development partners to come together and nutrition stakeholders, I would say, not development partners only, nutrition stakeholders to come and engage. And more recently, there is also larger development partner network, where coming together and thinking through understanding what the issues are and how we provide services is something that is there. So very valid point. Thanks.
Thanks for sharing that, Vijay and Dr. Rashmi. So, I mean, that was my last question, right? Like, what is it? What is that one action point, right, for us as an ecosystem to facilitate convergence towards improving nutrition outcomes for citizens? And Sampat sir had mentioned about practice, right, like practicing it ourselves and practicing it regularly. Vijay mentioned about how convergence within the institutions and a winning coalition is very important for the same. So, like, last words from the three of you to hear about that one action point for all of us to target for the next 2-3 years. So maybe Dr. Rashmi, if you want to start.
Well, you know what I'm going to say. Let's think about the child and mother and the household before we think about what else is going to happen and work back.
Dr. Sameer.
So action for us, not for government, because Vijay kind of
Action for
said
us.
that we
Yes.
should also think about what we can do in our domain rather than
Exactly.
preaching someone else. So yeah, I think he rightly said that there is also a lot of duplication that happens between partners and their priorities and their actions. My kind of action would be work with the system and demonstrate with the system on how it happens. Understand challenges and addressing challenges, then only probably you'll be able to really preach on it and take it to scale.
Piyush.
I think I'll put community at the center of everything I think of at first place, and always think from the point of view of the pregnant woman or a mother. The second thing which I would be thinking of is consistency in the efforts, and second, putting evidence into action. There are a lot of good things happening across the world and in India itself, and you see a lot of problems which have been solved at small scale, maybe in different parts of the country, and we are unknown about it. So identifying those best practices and helping them to scale, and I think that is something which I'll be looking for, putting that evidence to action for large scale problem solving, bringing consistency and putting community at the center of everything.
Yeah, and I think a lot of cross learning among ourselves, right? Like even within this group, like there are so many different examples of success. I'm sure like we have a lot of examples of failures as well, like just cross learning a lot more and deliberately will be really helpful in this journey. I would now like to invite my colleague Gunjita to like close the session and share some key takeaways that we will also circulate with everyone after this. Gunjita, over to
Thank you. Thanks, Parul. First and foremost, I'd like to thank our esteemed panelists, Sampat sir, Dr. Rashmi, Dr. Sameer, Mr. Piyush, for sharing their expertise and valuable perspectives with us today. It has been a truly insightful discussion. So when we began this session, we asked the question, how can meaningful convergence between ministries and sectors be conceptualized and practically implemented to improve nutritional outcomes for women and children? A few key takeaways emerged from the panel discussion, which I'd like to go through now. One, I think it's important to ensure convergence at all levels of the government system for it to sustain, for it to resonate through different levels, and for it to make an impact on outcomes. For this, it's essential to center purpose, which is center the community, center the outcomes at the level of the woman and the child, and really take that as our guiding star. We also discussed that convergence needs to be a regular practice, a daily and weekly, reflect in the daily and weekly tasks that we do. Second, the panel also discussed some practical examples of how convergence can happen. We took examples from Meghalaya, Gujarat, and Rajasthan, and several other states as well. Some powerful levers were explored that included data integration, joint planning and monitoring, and local level organizations that bring together programs working towards the same purpose. For the frontline workers and supervisory cadre, it is crucial to harmonize efforts and remove duplications, jointly identifying and managing at-risk beneficiaries, tracking children from identification to treatment, and building empathy between the frontline workers and citizens can help improve the outcomes that that are center of the work that we're doing. We also discussed for data that convergence is not merely about having a common platform, but an integrated single source of truth for each village, and that it has to be shared between different stakeholders. It should be used at all levels and shared with communities. However, it is also important to ensure that there's rationalization of the data that is being entered, that data entry does not become a burden and does not hamper local problem solving. Yeah, so those were the key takeaways I felt we had in the panel. I'd like to close the webinar by again thanking our panelists for the relevant and practical insights. I would also like to thank our moderator, Parul, for guiding us through this excellent conversation, and also the organizing team for managing the webinar. Finally, thanks to the participants for enthusiastically engaging for all of the questions. Yeah, thanks everyone.